Iba here from the Global Health Cluster. First rule that's going to come out straight away is that this is a small workshop for partners, so cameras on. I can see your face and go, oh no, she's confused, or oh no, she totally doesn't approve, or whatever it is. This is going to be informal. It needs to be engaging. It's not a meeting. No one's formally presenting. It's really about you getting to learn the tool, having questions, whatever it is. So Andrea, even though you're in the room with John, your camera on, please do. That'd be awesome. Yes, talking to you. Awesome. And as you can tell by the way I'm speaking, completely no formalities. In general, when we're presenting something on the screen, we're not very good at multitasking and either seeing the chat or a hands up. So just come off mic. That would be awesome. Just go, excuse me. And we'll go, yes, yes, yes. Because we're not with you. So it makes it just difficult if we're too formal. And you're all amazing partners anyway. So we're here to help. While we are waiting for others to join, and this is scheduled in case you think it's too long, can we go around and everyone introduce themselves and also put their names into the chat? I'm just going to throw it over straight away. I'm Iba from the Global Health Cluster, one of the technical officers. I'm going to hand over to John straight away, who's in that very formal looking room, but he promises he's not. He's adorable.
Hi, everybody. Nice to be with you. My name is John Fogarty. I'm the lead for primary care services in the Integrated Health Services Department. And I'm going to hand to my right to Parisa.
Hello, everybody. I am Parisa Kamali. I am a consultant working with John on SPDI and look forward to working with you today.
Hello, good afternoon. My name is Andrea King, and I am a technical officer with the Global Health Cluster. Hi, everybody. I'm Jenny Rasanathan. I'm a family medicine doctor. I'm observing / participating today. I'm also a commissioning editor at the Bulletin of WHO.
Back to you, Iba.
Oh, I'm going to head over, Melanie, because she's right in front of me. Big.
Hi, everyone. I'm Melanie Kempster. I'm the Health and Nutrition Director for Relief International. I don't know who to hand it to. I'm going to pick Julie.
Hi. I'm Julie Taft. I'm the Senior Director for the Global Technical Unit with International Medical Corps. Great to see everyone. I will hand over to Sandra.
Hi, everyone. My name is Sandra. I'm a Senior Public Health Officer with UNHCR here in Geneva. And I'm going to hand over to Liz.
Hi, everyone. My name is Liz Chong. I am the Regional Migration Health Consultant at the IOM Regional Office that's currently based in Bangkok. So nice to meet everyone. I would pass it over to Veena.
Hi, everyone. I'm new consultant with WHO looking at the MISP H3 alignment activity. I think I can pass over to Andre. I think Andre hasn't introduced himself.
Hi, everybody. My name is Andre Griekspoor. I work for WHO in the emergency program in the team that deals with protracted emergencies, among others. Been working over the last couple of years with Eba, John, and Nurayan, who I hope also joined by now. So maybe give the floor to Nurayan to
Yes,
introduce.
I'm here, Andre.
Hi,
everyone. My name is
you.
Nurian. Hi, everyone. My name is Nurian Zunong. I work with Save the Children as a senior humanitarian health advisor, and I also co-chair the Global Health Cluster Quality Improvement Task Team with Eva, and I'm based in Washington, D.C. Good to see everybody.
And then you meant to hand over, but I'm going to choose Daniel de la Torre.
Thank you. My name is Daniel de la Torre, and I'm advisor for challenging operating environments at the Global Fund. I'm going to hand over to Nadia Olson.
Hi there, I'm Nadia Olson and I work at JSI and I am our humanitarian and fragile setting lead at JSI.
Okay, I'm going to go back to this other screen. I've got Cora. Over to you, Cora Nally.
Thank you. Hello, everyone. I'm Cora Nally. I'm the Director for International Response with AmeriCares.
Fabulous. Julie Taft, Elaine Erasmus. Great name.
Good afternoon. I'm Elaine. I'm like Parisa, a consultant together, working with John on the SPDI. Thanks.
Okay, maybe Sandra, over to you, Harlas. Hi.
I already got, but I
Did
guess.
you?
Yes, you have too many screens,
Don't talk
my
again, you're not
dear.
allowed. No, you're allowed to talk as much as you like. Clearly, I've already lost it. So, Veronique, have you spoken? I'm on my next screen now.
Hi, everyone. I'm Veronique Verlick with the GHC Secretariat.
Awesome. Sorry.
I pass to somebody, Kayono.
Yes, hello everyone. I'm Kayono Nakajima from IOM East Home South African Regional Office. I'm Migration Project Officer. Thank you. Hand over to Yves.
Yep, Yves.
Hello, can you hear me? I hope you can hear me.
Perfectly.
Hello, I'm Yvette Gonzalez. I'm the head of the health program at TDH, Third Zone in Lausanne, Switzerland.
Great. Maybe handing over to Sonia.
Hi everyone, my name is Sonia. I am Global Humanitarian Director for MSI Reproductive Choices based in London.
Awesome. Neha?
Hi everyone, I'm Neha Mishra. I am a consultant with the Clinical Services and Systems team, working alongside with John, Parisa, and Elaine here. Nice to meet you all.
So clearly you have all the squad who are going to help us out with this workshop. And I think the last one I've got is Colleen. Colleen, hi.
Hi, everyone. I'm Colleen Gallagher-Thomas, and I am the Global Medical Advisor for Relief International here with Melanie. Thank you.
Perfect. So perfectly on time. We will go straight into it. If you haven't popped your name and thingy into blah, blah, blah into the chat, please do. That kind of helps us as well, to be honest. Although everyone's, we've got Melanie coming in from UK Med, and that although everyone has introduced themselves. Andrea, I can't remember how we're splitting this up, but I'll do the first slide at least, I think. Maybe the second slide as well. So welcome everyone. If you have got bandwidth, please put your cameras on, that'd be lovely. We are trying to make this as inclusive as possible. Have I lost everyone? Can you see my screen? Is that
Yes, worked well.
Yes. Oh,
Yeah.
wow. Okay, fabulous. So everyone on this slide here, and many of you have been involved in the development of the H3. Just for you to know today, helping you through this is myself, Andre, John, and Nurian. Everyone's already presented themselves. This is meant to be as informal and as engaging as possible, two-way. Any question you have, please do not put in the chat because we're rubbish. And just feel free to go, excuse me, and just go on mic. Okay. Even though we've been developing the H3 for a while, we released the guidance, finally got clearance earlier on this year, and because of that we're just making sure everyone's aware and familiar with this amazing tool. This is the guidance that goes with it, but John and his team will be walking through the tool with you and how it's applicable for you. In general, why do we do the H3? From the health cluster perspective, it's about accountability to affected populations. We had the World Humanitarian Summit in 2016, where many organizations, including agencies by themselves like World Vision and others, Save the Children, made commitments to defining an essential package of health services in the work that they do so that it's equitable across countries. But it's essentially the point being that when you have a package of services, the populations affected by crisis, they have a right to know what health services they're entitled to receive. So not only is it just about transparency, it's about transparency and accountability to them, but also ensuring that there's not inequity across the population or within a country or a setting. It is in line with UHC and HDN. We had the World Humanitarian Summit in 2016. After that, Andre led a task team to address these commitments around EPHS. SDGs came out, and thankfully, under John's side of the house, they, in November in 2020, they work on UHC, but also defining overall for the Ministry of Health what those services, different services can look like when they develop their package. So really action by action, service by service, and importantly, at which service delivery platform. So I would say UHC, the compendium, as it was called, was developed in December and launched in December 2020. We were going through COVID-19 at that point, and we were deciding what services do we protect or suspend. And it always came back to, but we don't know what those services should be or not. And so this is why a package is really useful. And when the UHC compendium was launched in December 2020, it was a pivotal moment for us to say, okay, this is great. From this set menu in humanitarian response, we can be accountable for this minimum subset at this XYZ level. And collectively with you all, we developed the H3 package, which is a reference package. Andrea, did you want to take over?
Sure, happy to do so. You continue showing the slides, otherwise things.
Yeah, I'll be doing the button.
This one is mine. Yeah, okay. So they'll start looking the same at some point. So just picking up from where Eva left, the idea of this humanitarian response package is that we defined a set of prioritized services that can be delivered at different levels of healthcare or service delivery platforms. I'll show that later. The whole idea behind it is that it was sort of a minimum reference of services that we are and should be able and can deliver to populations affected by crisis. So there's a difference with our approach and what we call aspirational packages, where ministries can throw in a lot of things that they would like to do, but simply the capacities are not there yet. The other thing is that as a result, it is an explicit reference for humanitarian partners to compare themselves with. When we developed it, we looked at a lot of reference packages that were already out there, including the MISP, DCP3 high priority package. And we also looked at packages that were made in different countries. I think for me, one of the major things that moved this work further compared to the work that we did with this EPHS task team is that we could now align and feed our selection of services from this UHC compendium. And I think also you'll see when John is presenting how this works in the SPDI platform is normally you present a package and you see what we selected, but you don't see what we didn't select. And I think the SPDI platform and linking it with the UHC compendium of services, if you want to adapt your package, you can actually look at the full menu of services and interventions that are available in this platform. Now, one thing that we made a conscious decision on is that the work that we did was for protracted settings that are more or less stable with decent access, regular ability to support supply facilities. And it's not meant for acute emergencies or rapid response mechanisms. So when we were contacted by Sudan and Gaza, how can we use it? Not as it is, but just like the work that Eva explained on COVID prioritization, you have a package that you do in let's say normal emergency times, in a more stable, protracted emergencies, and then when there is a an exacerbation or acute phase of the crisis, you do further prioritization. And this is what we also try to do with Gaza and Sudan, that we help select services from H3 that are really critical, urgent, life-saving, and then services that could be suspended for when the situation further stabilizes. Next one. So why is this useful? There's 2 or 3 dimensions for it. For individual partners, you can basically see and have a look at this whole database of the UHC compendium. You can then also compare what you as a partner are delivering or not compared to the H3. And I'll come back to that later for the adaptation at country level. But also in the SPDI platform, when we adapt the H3 to national context, we always use the national package as a reference. So when you are working in a specific country and you're looking at what you can deliver as a humanitarian partner, you can also see how the humanitarian response package compares to the national package. Next. For the health cluster, the idea is that H3 needs to be contextualized to the particular setting in which we work. Same as for the partners, we do this adaptation and contextualization also informed between the national package. So we have the H3, we have the national package, and we have criteria for contextualization. And also the thing that needs to be contextualized is that we use standard terminology for different delivery platforms, and that needs to be adapted to the terminology in a particular country. And then you can also use the H3 and the definition of what should be delivered at what level of care to develop your response, your operational response plan, and see what mix of service delivery platforms are the best way to deliver services in different operational security contexts. I've already mentioned supporting accountability to affected population. A thing that is also a bit my hobby is the interface of this work with the humanitarian development nexus. I hope you're not all switching off now, but one of the simple practical starting points of HDN is that we align, harmonize to the extent possible our humanitarian response with national references, policies, standards. So our ability to define the humanitarian response services with a national package is one of the starting points of the Nexus. But at the end, if you still have energy over and when John is done with his practical stuff, there's a few other suggestions how we can use the definition of a humanitarian priority package to operationalize the Nexus. And the other thing on the practical side is that, and John will show in detail, the package also reflects all the resources and the staffing that you need, the medicines, and so you can actually push on a button and you get the whole list of medicines, and you get standards for staffing for different levels of service delivery. And you can also use it to identify where health workers require additional training to do some services that we consider to be core, but for which they require some short in-service or short duration training. Also can use it for monitoring progress, making services available, and investments needed for quality of care. Now, this one, this is sort of an overview of the process that we went through to make what we have. On the left side, we started with this core group, and on the right side, you have the final review, and in between, there's a whole process of making a first draft, reviewing it, mapping it to the compendium, and using expert groups to validate what we drafted, and then a final review by the core group, and the result is what is now out on the web. So just to acknowledge, there was a lot of people who contributed to this. I'm not going to name them all, but we'll share the slide set with you afterwards. And the next slide is just to show you that we had 6 separate sets of validation groups with experts to look at the distinctive components of the package. So one of the things that we did, and what you will also need to do or reflect on when you adapt packages to your operational context, is what are the criteria that we use to select which services should be in and which services should be out, which services should be that are desirable, but the resources are simply not there yet to actually implement. So we made a distinction between core and extended, and the conditional I'll explain later. Core is what we expect are services that can be delivered. Extended, they require more resources. The medicines for them are not included in the humanitarian medical kits, or the upskilling of health workers would really require formal training of 6 months or longer. Whereas then evidence-based, time-sensitive, so obviously a link with main causes for morbidity, mortality, high impact, high value added, low cost. Feasibility. It's good to keep in mind that the feasibility to deliver a service is not linked with the capacity of the partner. It's linked with the ability of the health worker, the highest level health worker, or the mix of health workers that are the standards for the different service delivery platforms. So for OPD services, we assumed that there would be a qualified nurse being able to do outpatient consultations. And we expect that the national training for these nurses in countries where they have nurses at that level allows them to make diagnosis and treat the illnesses that we included in core. If it was something that would exceed the range of a nurse in settings where you have a nurse in OPD, we packed that service at the first level where there was a medical doctor. Equity, the idea is that it can be delivered to the entire population in need, so not only in areas where you have specialized NGOs or the other obvious thing is that the service, the range of service need to be clinically effective. So everything that is really needed to make that service to treating a certain morbidity or a certain condition, it needs to include all the components that make that service really effective. The other one, last one, is on the humanitarian imperative. It's sort of a loose term that we used for including services and treatments and support to patients that may not make it to the top 10 of the burden of disease or mortality, but that have a humanitarian connotation or that are included among the humanitarian priorities, such as helping people to recover from harm when they have been affected by gender-based violence and other of those types of conditions. So extended, health workers need extensive additional training or the drugs are not in the currently used kits. Conditional was a concept that we didn't use for H3. We included everything under core that we assumed could already be delivered by health workers in low resource settings. But there were some services or some, it's not really treatment, but it's more things around counseling or the softer support and that health workers give to patients that might require short training courses. And then I'm talking about 1 week or 2 weeks at most, or that can be taught to health workers through basic in-service training. In the country adaptation, we would call them conditional. They are core, they can be delivered, we should commit to it, but it's conditional on doing some additional short training or adding some medicines that are required to deliver that service. This is just a warm-up on the different delivery platforms that we will look at. So it's community, outpatient. We added a platform for birth and delivery care, which is basically derived from the MISP, and it includes services that kind of otherwise fall in between the chairs of outpatient and a first-level referral hospital. In most countries, this delivery and support to birthing is included in a comprehensive health center. So it's an OPD with inpatient and delivery care. But to keep things manageable, we added it as a separate delivery platforms. And then you'll see that in the coding of H3, green if we selected it as core, orange if we classified it as extended. And as I mentioned earlier, with the help of the compendium, you can now also see what we didn't include. And we defined the highest level of health worker that we expect to find in low resource settings at these different levels with some very simple definitions for them. What we are currently doing with Safer Children is we're adding a platform for mobile clinics. And Narayan, maybe you want to say a few words on this?
Yeah. So as Andre mentioned, at the moment, we don't have a mobile clinic as a service delivery platform, but we are in the process of finalizing the list of services. And we are looking for volunteers to join the expert validation process for the list of services can be safely delivered via mobile clinic in the humanitarian settings. So if you are interested, please let us know. I will stop here, Andre.
Okay, people will have questions later on. Next slide, Emma. So, and this is where we're getting into how you can adapt and apply the H3 to your particular operational context or to your agency. It does need to be contextualized. We have a reference package, but that's not written in stone. In every context will be different. The training of health workers at the different levels will be different in different countries. Their resource capacities will be different, but also the morbidity that you will encounter in different countries will vary. Some areas there's malaria endemicity, others are not. But it's also around how far can you go with treatment for NCDs, and how serious are health threats around gender-based violence and other risks. Typology of the health network, so the equivalent for outpatient or clinic, many different terminologies. You need to obviously translate that to the terminology used in your country and align with it. You need to adapt the standards for staffing as they apply in your country, your context. We again used nurses at OPD level, doctor at first level referral, and specialist at second level referral. In some countries, you will have doctors at outpatient level, for example. And then obviously you need to things that we thought were not realistic, not feasible at that level with a nurse. You can add those services then at a lower level. And this is basically how you make the adaptations, that you can either shift services from higher levels to lower levels when the health workers are able to do this. You put it at that lower level. If you feel that certain services are not relevant or not appropriate in your context, you can delete them, make them gray. But you can also now draw from that pool of services from the compendium by adding things that we did not consider in H3. And there's just one message, and really we're struggling a bit because some countries that are in middle or in high income countries, they say, yeah, but H3, that's that's for low income, low resource setting, and it's not relevant for us. And there's a bit this thing that, okay, it's designed for South Sudan or Somalia or Yemen, and we're here in Ukraine and it doesn't apply to us. No, not in the way how we defined it, because we took the lower level of resources. But if you're in a higher resource settings, you still need agreement on what the services are that you commit to. And then, as I said earlier, things that we put at higher levels, you basically put them at lower levels if you have more highly trained health workers at lower levels.
Okay. I'm going to stop sharing. I just can't work out how to do it. We're going to move on to the demo bit and play, which has nothing to do with me. So I can stop sharing. Did I stop sharing? Yes.
Yes,
Okay,
Eva.
I just want to quickly say hi to Bilal. Is it Melanie? Bilal's from IMC. Melanie, is it? I don't know. I don't see it in the chat. And then Dr. Sohee Hang from Mercy Malaysia. But Melanie, you're from UK Med. Just reiterating, please come on camera. Please interrupt. Please ask questions. Try not to use the chat for questions because we're not very good at it. Feel free to come on the mic and just say, excuse me. It's meant to be engaging. And this is the bit where you will have lots of questions. And this is the bit where you will work through stuff. So John will be leading you through that. But yeah, reiterating that, and to Bilal, and Melanie, I believe. Okay, John, definitely over to you now.
Great. Hi, everybody. So we are going to play some speedy bingo. And we want this to be very interactive. So feel free, as Eva was saying, stop, ask questions, put something in the chat, but also use your mic and interject. We want this to be as useful as possible and as interactive as possible. So all of you should have gotten an email asking for you to activate your account. We are going to do a demo. We invite you to follow along live as we go through this so that you can learn how to use the resources, use the Speedy platform that has been developed to support countries. So really nice to be with you. And it looks like we have a great turnout today. And again, want to make this as practical as possible. This is the landing page for the Service Planning, Delivery, and Implementation Platform, or SPDI platform, which was developed by WHO in the last 4 or 5 years. And you can access it. We'll put it into the chat. You can access it at uhcc.who.int, uhcc.who.int, and there you will be able to log in. And with the account that hopefully you were able to get. We've created accounts for everyone that signed up for this session. So you should be able to log in, and what you could do is you could log in with an email that you use to register for this session. And then the first time you log in, you may be asked to put in a password. So you can do that in the upper right-hand corner. You'll see a login button. This platform, the SPDI platform, as I mentioned, was developed over the past 4 or 5 years by WHO. There was a huge number of requests from member states, from countries, to get support for the design and, most importantly, implementation of packages of services for universal health coverage, UHC. So countries were saying, well, how do we make progress towards UHC? We want to do a package, but how do we do it and how do we implement it? So more than 50 programs across WHO contributed to this, so that literally hundreds of focal points from WHO. And behind this is a huge database of resources for products, devices, medicines, WHO reference, guidance documents, as well as links to costing materials. So countries are using this to do costing. So it's really a powerful resource. We have been using the H3 package, which can be found on here, and I'll show you how the H3 package can be used as a reference, and then how you, working in a humanitarian setting, can be able to use it to design a package of services for humanitarian response and to create accountability for those who are actually delivering the services. So I'm going to just walk through a couple of examples just to show you how it's done. If you've already logged on, you can go ahead and log in and you can follow along. In about 10 minutes, I'm just going to show you how to create a package, how you, and then we can follow along together, and we'll play Speedy Bingo. And the winners of Speedy Bingo, next time we see you, you will get some Swiss chocolate. So there are stakes involved. Chocolate, not steaks, but in the upper right hand, actually, let me just start. I'm going to show you, I'm going to use as an example the health cluster in Bangladesh, in Cox's Bazar, actually had developed a package of services recently. This is just one example of one of the outputs. So the Cox's Bazar package, they had used this to define, first of all, at a high level, the services that would be included, a comprehensive set of services. And then importantly, they mapped those services to their context-specific delivery platforms. So the community level, health post, PHC level, and a field hospital. I'm going to show you how you can contextualize a package to the health system in which you're working. So defining the delivery platforms that are most relevant for the health system where you're working. But just to give you an idea, that's one example of a package that was developed very recently by the health cluster and with the Ministry of Health in Bangladesh. Let me walk through just a couple of quick examples so you can see how the Speedy platform works. In the upper right-hand corner, you can log in. Once you log in, you will see a section that says My Projects. If you're having trouble logging in, we have, you met Elaine, Nihan, Parisa, who are online. They can help you if you're having trouble. So just put your question in the chat or your difficulty in the chat, and they will assist you. This is my dashboard for the Speedy platform, and it just shows that many countries are using it for a variety of different purposes. It may be used for a national package like UAE or Jordan. Kyrgyzstan just developed a national package for universal health coverage. I mentioned Cox's Bazar is doing work. Other countries are using it for program-specific packages. So it could be used for many different purposes. We are going to focus on the specific purpose of developing a humanitarian response package. So this is the Cox's Bazar package, and I'm just going to walk you through how a country can use this structured architecture to go systematically through all health areas to consider what services might be included. And they can also use it, and many countries as well as humanitarian partners have used it to be able to understand current service delivery. So by going systematically through all these areas, they're able to see where there might be gaps in their current service delivery, where they might need training for their health workforce or health products. So let me just go through an example here. I'm just going to scroll down to, let's say, non-communicable diseases. And if you're online, you can follow me. So again, it's a structured architecture to consider all health areas. We'll go into non-NCDs and mental health. And then,
sorry, should we go in our, if I go into my projects, there's a test QUITT. Should I go into that, or should I, if I'm following along, what should I go into?
I think you guys are advanced. Let's do this. Let's go ahead and make a package for you guys. So here's what you can do. If you go to My Projects, we're going to start out this, we're going to move you guys to the advanced level already. So In the
John?
upper right-hand corner, yes?
Sorry,
Eva?
just to interrupt. I think Nadia needs to create an account or something. Can someone in your team support her? Because I don't know how to do that.
Yep.
Yes.
Yep, they're
Okay,
online.
great.
So just, Nadia, if you put in your email, we will send you information right now. So everybody else who has an account, if you're on My Projects, in the upper right-hand corner, you'll see New. So go ahead to go to New. And then you're going to be taken to a configuration page, and this is where we're going to create a new package. I would be grateful if you could start your name with H3-test, and then you can put in your name. That way, we can keep track of it as to who's logged on and who's put in their information. I'm going to go ahead and just put in a country. I'm in Switzerland right now. And then I'm just going to say finish. So just put in your name and then put in your country. It's a country package. It's not a global reference package or WHO reference package. I'll show you later how you might start with a prior package. Don't do that right now. What that does is it imports all the services from, say, the H3 package. And then I'm going to say finish. And it says package was saved. So now I have my test H3 package, and I'm still in the package configuration page. And now I'm going to create, I'm going to contextualize or customize the delivery platforms here. So if you, on the left-hand navigation pane, you will see options here. About fourth from the top, you'll see something called delivery platforms. Go ahead and select the delivery platforms. And what you will see are the default delivery platforms that are in the UHC compendium. So there's community-based services, pre-hospital, general outpatient services, first referral level, and second referral hospital. What I invite you to do is using your specific humanitarian setting, think through what are the delivery platforms that are available in your setting and contextualize it. So right now, I'm just going to actually think back to what they're using in Cox's Bazar, which is community-based services, community services. I'm going to update that. They're not using pre-hospital emergency care services. I'm going to delete this one. So I'm going to go over here and select delete. If you are in a humanitarian setting where, say, you're using mobile health teams, you may want to convert this name. You could say this is a mobile health team, a mobile health clinic. That's spelled very well. And you could change this to a mobile health team. And I can say update. And I'm linking it to the pre-hospital services.
Sorry, could you share your screen again, please?
Have you lost my screen?
Yes.
Can anybody else see my screen?
Yeah, I can see it.
I see it.
Yes, we can see it.
Oh, sorry.
Sorry, Colleen. It looks like others are still, we still see it here. I think others are still seeing it. Maybe shift your view or something, perhaps. Maybe it's under your screen. So going back to the configuration again, you can contextualize it for your system. I'm going to change general outpatient to primary care to PHC clinic, and the first level hospital is actually a field hospital. And I'm going to say we're not going to use second referral level hospitals in our package, so I'm going to delete that one. And then I'm going to say update, update. So now I have a community, mobile health teams, a primary care clinic, and a field hospital. I'm going to say finish. And it will change this package to those delivery platforms. One last thing we should do before we go to mapping services. In the left-hand side, you'll see the navigation pane. You'll see reference packages just above delivery platforms. Click on reference packages. And under the reference packages, this is where you will find the H3 package. So if you are working with a country, you might, like, for example, in the Cox's Bazar example, they wanted to look at the Bangladesh package. In Gaza, they wanted to look at the package that was developed for OPT. So if you have access to the country package, you can use that as a reference. But for this example, we're going to show global reference package. So you can see there's a number of reference packages. Some of you may be familiar with the disease control priorities, or DCP. You can use that as a reference. You can also look at the H3 package. So down at the bottom, if you click that drop-down menu, you can see the H3 package, and I'm going to select that. There's also a number of WHO reference packages like IMCI, Violence Against Women, WHO PEN. If a country is interested, you can use these other, and I'll show you how to use those reference packages. So I'm going to say finish. And now we basically have a package ready to start mapping in services. There's other functionality. Happy to show you this at a later time. You can define the users who would be involved. You can bring in high burden diseases, things like that. But so we say finish, and then we're going to go to up in the middle at the top, you will see the option to go back to package. And so we're going to go back to package. And this takes you back to a dashboard where you can see the structured architecture that's in the UHC compendium and in the SPDI platform. And again, the purpose of this is to make sure that countries. Yeah, go ahead, Eva.
Sorry, someone's raised their hand. Vina.
I had just had a question on the page that you had just now. When it comes to country packages, it says add country package. Would it be possible, like, so in a country, I tried with Bangladesh, but there was no drop downs for that country package. But is that the idea, that there would be country packages already on the platform for us to be able to explore?
I like this question because we had this yesterday as well. So clearly,
yeah, thanks, Eva.
for everyone.
Thanks. Yeah, thank you for coming in. That's actually a great question. And the answer is yes, the country packages can be available if you're working with the ministry and they grant you privileges. Currently, we don't on the SPDI platform give access to partners unless they're to a country package, unless they're working with a Ministry of Health. Just because some countries, it's confidential, they don't want that widely distributed, they don't want it publicly available. So it doesn't mean you can't. We used it in, for example, Kyrgyzstan. They started with their 2020 package. Many partners have access to the national package. So we would be happy to discuss that with you. And we work with many ministries of health, and most often they're very happy to do that. But that's why you don't see it here right now.
Yeah, and if you were in a health cluster that was developing a package for the health cluster, they would be using the national package within that to be able to develop it. And so anyone who's involved in that H3 development would be able to see that as well also.
And just linked to that, like, so for example, if you do work with the Ministry of Health, do you request them to grant you access, or do you request access through the WHO?
One thing to do would be to work through your health, the health cluster focal point, and then contact our team. And then we can see if the package, the national package, whether it's already in the SPDI platform. And if it is, and that there's permission from the ministry to be able to share it with the partners, then it's a fairly straightforward process. And again, as Eva said, if the cluster is already involved, then usually the ministry is involved at some level.
Bilal's raised his hand from IMC. Hi, Bilal.
Hi, Bob. My question is related to the delivery platform. I'm not sure if you can show it again. How can we change the service level because I'm trying and I am unable to do it. So is it because we don't have permission to change that, or how is it?
Let's see. You should have permission because it's your package and you should be the administrator. So I'm going back to the configuration page on the left-hand side. I'm going to go back to delivery platform here. And when you're saying you're not able to change, what is it that you weren't able to change?
Maybe
Sorry,
it's
Bilal.
if you can try doing it again, and I can then follow you because I
Okay.
tried to add or delete, but it says you don't have the permission.
You know, you might, but you know what happened, Bilal? I think you're not logged in. So we will send you some instructions. If you go back to the landing page, the home page, just make sure that you go, here, I'm just going to go, sorry, everybody, I don't want you to get dizzy here. Let me, I'm just going to go back to the landing page here. In the upper right-hand corner, it should say log in. Make sure you're logged in. And then go to My Projects. And then you need to create a new project.
Yeah, I did that.
Did
I was
that?
able
Okay.
to create a new project, and then I was just following you on it, but I'm unable to make the change. I mean, I went to like the delivery platform, but then if, for example, I want to change something, just like, for example, you change the pre-hospital emergency care like to the mobile unit, so then I'm unable to make the change. Oh, it's working now. Okay, I can do it now. I think I don't know, maybe
Great.
some other reason.
All right.
Thank you.
Awesome.
We'll blame
so
the fairies. We'll blame the fairies in the system. Sorry.
The speedy, yeah, the speedy
Those
fairies.
fairies,
All right, I'm going to go back to package here. And if everyone goes back to package, I'm going to show you how you can begin to add services to your package. So let's go into non-communicable diseases and mental health. The structure of the Speedy platform is such that it's a nested architecture, meaning as you go deeper into the architecture, you see more details. So under NCDs, you can see quite a comprehensive set of NCDs. Now, for a humanitarian response package, there are many areas that you might not consider. You might not have services for autoimmune disorders, but you may have some basic services, say, for chronic respiratory diseases. In fact, let's go into chronic respiratory diseases. So go ahead and select chronic respiratory diseases. And you see there are two what we call intervention categories, one for COPD and one for asthma. So we can go into asthma. And as you go into this intervention category, so there's services for prevention, screening and diagnosis, management of acute exacerbations, and longitudinal management. As you see these selector buttons under the interventions, then you can see the specific services that might be included. So there's the list of services. On the right-hand side, you can see the specific delivery platforms that I just contextualized. So a community delivery platform, a mobile health team, a primary care clinic, and a field hospital. So it allows you to be able to consider the services and then be able to map those services to delivery platforms. Let me show you one other thing. If you scroll up, you'll see something called reference packages. And if you select that, and if you had turned on in the configuration, the H3 package or other packages, you can select that. And now what you'll see is a handy little guide, which may be helpful. So you can see what is in the H3 package. So if I go to, say, longitudinal management of asthma, I can now see that counseling on a personalized asthma management plan is mapped to the hospital level, whereas the inhalers, beta agonists, corticosteroids are mapped to the PHC or primary care level. So you can use that as a reference. It needs to be contextualized for each country. So every country will, or every humanitarian response will have different capacities. One of the things that can be really powerful at doing this is to use this to map current service delivery. So for example, you may say, well, we do have currently inhaled beta agonists at the hospital level. We, however, aren't doing it at the PHC level because we just don't have the medicines. We don't have the products. So there's another option to be able to contextualize the delivery platform. So you can, if you hover above the radio button, you'll see 3 dots, and you can select those dots, and it gives you more options. And you have the ability to define the service in other ways. And countries and humanitarian partners have used this in a really powerful way to be able to identify where there are gaps or bottlenecks with current service delivery. So oftentimes a country or partners will start out with mapping their current services. So you say, inhaled beta agonists are being delivered at the first level hospital, but they're only conditional at the primary care level because a lot of our clinics currently don't have inhaled beta agonists. And you might say, counseling on a personalized asthma management plan is also available at the hospital, but it's not done at the PHC level because our health workers haven't been trained. It could and should be, but it's not being done because the health workers have been trained. And then you might say, in the long run, boy, we'd love to get inhaled beta agonists at our mobile health teams, but it's not even part of our plan. So we're going to call this an extended service. So if we can get enough resources, we'll be able to do it. Anyway, this is for illustrative purposes. Different countries use this classification of the services in different ways. Again, the most common way is the green is a service that is currently being delivered. Conditional services can be used to identify where there's gaps or bottleneck, and an extended service is a service that you'd like to be able to add. And then the references can be used to be able to help guide the selection. So you might say, this is in the H3 package. Yeah, we'd like to add inhaled corticosteroids as part of our package. You could say, this is a conditional service because we're not currently doing it, but we're doing inhaled corticosteroids at the hospital. Let me stop there and just see how you're all getting along, and I'll show you, and then we'll move on and show you some other fun things. I'm sure you're doing other experimentation to see, like, whoa, what happens if you hit here, and what shows up there. So we'll go into that. But let me stop and see if there's any questions right now.
Everyone experts? Yes. Is it making sense? Is it weird? Super detailed, but there's other functions that we can do, which John will come to in a minute. But if people have got, Sonia says it's very clear. Nothing to do with me, clearly, because it's all about John and his squad. Anyone else?
Could I just ask, just to go back a couple of steps, how you got to this longitudinal management of asthma? I think I missed that, and I'm struggling to get back to that page.
Thanks.
Sorry.
Great question. And let me just point out here that this platform is on a WHO server, and it is protected by the Azure security system. And that's why it requires you to get an account. If you are not actively engaged with it, sometimes it will log you out. So it's just log me out. If you log out, you just say, okay, and then you go back into the upper right-hand corner and you say log in. If you've already been logged in, your browser recognizes you, it will take you just back. And then you go back to my projects. And
so I've just popped in the chat the clicky thing. I don't know what it's called. The link, the thing you click. From the packages, you go to NCDs and you follow those choices, and that should go down to asthma. Has John been logged out? John, you don't work.
Yeah, it knocked me out.
You're not
I have
useful to
I mean,
this process at
my
all.
Chrome quit. It was like, you're done. So Chrome quit. Anyway, I'm back.
Don't make anyone else present this because we will not be able to do it.
Oh, that Speedy Bingo's coming up, guys. Swiss chocolate. Going back to my projects here. Oh. No idea. I don't know. It keeps. Teresa, you might have to drive the bus here because it keeps. My Chrome is quitting. I have no idea.
You're welcome to use mine as well. No.
This is Humanitarian Response 101. Everything changes second by second and we all shift.
I'm back on.
Yeah, should I share?
Let me, I think I'm back on. Sorry, guys.
Yeah, Andre and I are silently panicking, and I'm sure we're going to start sending WhatsApp messages to each other going, not me, I'm not doing this, I'm not taking over, please don't. So Parisa, glad you're there.
I can take over.
All right.
Is it working? Yeah.
I think it's working.
Great.
Sorry about that. Okay. So I'm going to go now into how do we navigate back to asthma. There's a couple ways you could do it. One is you could do a search.
Oh, that was fun. I didn't realize my mic was on.
What happened? Okay, so you can do a search for asthma, and that will take you. You can say, oh, I can go to asthma directly here. I can go to longitudinal management of asthma, and it will take you back to asthma. Does that make sense?
Mm-hmm.
Okay, so once you're back in, let's go back here, and I'm going to show you a couple of other features. In the UHC compendium, I mentioned that there's a huge amount of data that underlies the resource. So if you open a service or you open an action, you will see information, more information. So links to health workers, links to medical devices, lab tests, medicines, links to WHO references. So all of that is in the back end. Here, it can be helpful sometimes for countries for additional information or partners. There are exports, and I'll show you some of the exports that are available that have this information that can be really useful. Like, for example, how do you contextualize the medicines that are available in a package? Okay, let's play Speedy Bingo. So I would like the first person to get to add oral antimalarials at a delivery platform and can describe how to do it. They get some Swiss chocolate when we see you next. Oral antimalarials as part of malaria. I'll give you a hint. You can go back. You could do a search here, malaria, or you can go back to the all here, and you can see the structured architecture. You could go to communicable diseases, maybe, or you could do a
oral antimalarials for whom?
You can add it to whatever your lowest level delivery platform is. You want to be able to have oral antimalarials, ideally at the community level, if you can, and make that a conditional service. Did anybody win? Who?
My
Okay,
God,
who's online?
Sonia.
Fantastic. Who won?
Sonia.
Who's the winner?
Sonia.
Sonia, do you want to share your screen and show us how to do it?
I can try to share my screen.
I'm going to stop my screen. All right.
Actually, I don't usually use Zoom. I have no idea how to share my
Oh,
screen.
me neither.
But I can
Me
talk you
neither.
through it. So I went back to the main screen of all services and all categories, and then I just in the search bar I typed malaria, and that then generated all the options with malaria in it. And so then if you scroll down, there is oral antimalarials. Yeah, that's the one.
You did it super fast. You get like 2 boxes of chocolate, I think.
Great.
Yeah, exactly. So what you found was that you can actually do a search. You can see at a high level what we call an intervention category or interventions. You could get to it that way, but you can also see the specific service and action. So you found it here. So if you press oral antimalarials.
Yeah, that's the one.
Yeah, there you go. And boom, it takes you right there, and it'll even highlight them for you. And then you can select it. So did you select it here?
Yeah, I just clicked on the green one, and I had already posted the screenshot in the chat, and then you said, oh, it needs to be conditional, so I had to modify the color. So I have 2 screenshots.
2 gold stars and a box of chocolate.
John,
Teresa's keeping notes, so we have we'll make sure next time we see you, Sonia or any of our colleagues will send you some chocolate from Geneva.
Glorious!
So
can't wait.
So that's
okay. Just to add, John, it's only Sonia. It's only conditional if, in your context, the community health workers have not been formally trained on providing anti-malarials. We discovered when we were doing this work, I also anticipated that all community health workers are able to treat diarrhea, acute respiratory tract infection, and simple malaria. But that turned out to be not the case in all countries. So if in your context they are able to do that, it was part of their normal training, then it's a core service at that level. If they were not trained, but you consider this absolutely important and critical to add to your particular context, but the health workers need a 1-week training on it or a 3-day training, then it's conditional.
Brilliant. Thanks, Andre.
Just a question.
Great.
Did we look at malaria in general? Because now we are in the antenatal complications. Is that where we wanted to go, or did we
I
want
made a mistake there.
to go? Hey, so I get chocolate too?
You do, Sandra. You do. All right, Sandra gets it as well. So here we go. How did you get there, Sandra? Tell us how you got there.
No, the same way. I just clicked on a different one. Same way with the search.
Right.
Yeah, I just clicked and I saw the different options. I went a little bit longer, to be honest.
So you'll see sometimes there's crossover. So anti-malarials are really important in pregnancy. So sometimes there are services that are found in multiple intervention categories. But you could get to malaria if you went to communicable diseases, the structured architecture. And so within communicable diseases, you can see communicable disease prevention, which is primarily immunizations. There's a big section on NTDs. Some countries, like Ethiopia, really wanted to emphasize NTDs as part of the humanitarian response package. Other countries, they provide just a minimal kind of set of services. Again, if you look at NTDs, there's quite a comprehensive set of services for NTDs. But then if we go into other communicable diseases, you can see there are services for HIV, TB, malaria. And if I go into malaria, prevention, screening, so you might see antimalarials in a number of areas like prevention of malaria. There's oral antimalarials for chemoprophylaxis, management of malaria, oral antimalarials for that. And then again, you can open it up. You can see there's a lot more here for oral antimalarials. I'm going to show you how this links to WHO essential medicines lists. I'm just going to click on one of these and you'll see it. It has a link to the EML, the essential medicines list. And I'll show you an export that you can actually produce after you've developed a package. And you also can contextualize the medicines based upon, say, if you have a formulary that's available in the country, you can contextualize to the national formulary. And I'll show you what Gaza just did last week, actually with Andrea here, and how it can be used actually in a humanitarian setting to link to emergency health kits. So, but let me stop there, see if there's any more questions. I'm going to add oral materials here.
John, there is a question from Mina. Mina, do you want to come off mute and ask your question?
Yeah, I'm not sure if it makes sense, and I apologize if it doesn't, but so we clicked under global reference packages H3, right? And now the markers are showing us what is reflected in H3. If we use one of the other emergency global reference packages, will that also be reflected, or this is just for H3?
You're so full of great questions. Yes, let's add another, let's do this. Okay. New opportunity for box of chocolate. Go ahead and add another global reference package. How do you do that?
My question, because each time I do this, I learn
No,
something.
you don't. You are
No,
not
it's a
eligible for
question.
chocolate.
It's a question. Before I go back to where I'm going to go to get another package, can I confirm that everything's just like automatically saving?
Thanks for the question, Eva. In fact, it saves automatically all the time. It's always updating.
Oh, Melanie's won the chocolate.
Oh, Melanie, tell us, Melanie, how did you do it?
Oh, Sonia's just behind. Too late, Sonia.
Oh,
Too late.
she can't have any more chocolate. She's already got some.
All right,
I
Melanie,
went
how do we do
to
it?
configuration.
Right,
I
configuration.
went to reference packages.
Nice.
And then I added another reference package.
Did you go under global reference packages or WHO packages?
I went to global reference packages.
All right, great. So you can see there's a number here. DCP, again, we pulled in if any of you are familiar with the disease control priority packages, they're used in some countries, actually Bangladesh is one of them. And they, however, those packages are not oftentimes well defined. Sometimes they're defined at a fairly high level. Sometimes there's gaps in them, but you can add them. You can also add in other ones. So EMRO, for EMRO countries, actually defined an emergencies package, which fortunately is very well aligned with the H3 package. So if I can select the EMRO's emergencies package, and you can see when I go back to, I'm going to say finish, that's going to add that package. The more packages you have, you might notice if you add like every single package, you might notice some delays in loading, because basically what it's doing is pulling over all those services in all those other packages as a reference. So it might be a little cumbersome. I'm going to go back now to malaria. I'm going to go to communicable diseases and look back in malaria and see what happened now. Oh, hey, let me show you a little handy little tool. On the right-hand side here, as we're kind of navigating through and you're looking at the different categories, on the right, you can see a little banner, a little badge, a little icon, and you can see the reference packages, and you'll see malaria is included, services for malaria are included, the EMRO emergencies package as well as the H3 package. That's gives you a little hint. Hey, look here, these services are important in these packages. Now I'm going to go back to management of malaria. I'm going to turn on this reference package again, and now you see which reference packages are active. So you can see the H3 package and the EMRO package. I'm going to select it. And now I'm going to go back over here and look here, and lo and behold, now you see both the EMRO package and the H3 package. And this is how, actually Cox's Bazaar, for example, they wanted to look at, they had a previous package that was developed in 2020. So they wanted to build on that as a starting point. Many countries will have their original package, and then they might use also the H3 package. So they're taking different inputs about what they would include. So that's how you can use a reference package. Let me see if sometimes though, if a if a service is extended, you will see like a little orange dot. Like the H3 package sometimes has extended service. I guess malaria, they're all pretty core services. Maybe vaccine, let me see.
Guinea worm or something.
I think vaccination actually for malaria was approved after the H3 package was started, so it's not there yet. That's why you don't see it.
Vaccination RTS.
Yeah, vaccination RTS is malaria vaccine.
It's in prevention.
Yeah. So the H3 package will be undergoing some updates, including having the reference package for mobile health teams, which is not currently in there. All right, let's see. Another speedy bingo question. This is from Parisa. Actually, Parisa, Parisa's sitting here with me. Go ahead, Parisa. What's the next bingo question?
The next bingo question, add the delivery platform Birth Clinic as a delivery platform before the PHC level.
Oh.
And it links resource and cost estimates, which is similar to the general outpatient services.
Can you repeat the question?
Yeah, she made it hard.
Yeah, it's Swiss chocolate. There needs to be some kind of. So add the delivery platform Birth Clinic. Yeah. And the Birth Clinic delivery platform is sitting before the general outpatient services.
Before your primary care clinic, if you have
Primary
one.
care clinic, yeah.
Between the community and the primary care clinic. Mhm.
And then you should link it to resource and cost estimates, which is similar to the general outpatient services.
Yeah, you made a hard one. I guess you didn't want to make it easy to do.
I have no idea what you're talking about, but I'm going to play. Maybe Sonia will teach me how to do it.
Can you say it one more time?
Okay, so we're going to create a new delivery platform called Birth Clinic. And this delivery platform should be between the pre-hospital emergency care services and the general outpatient services. And then this new Birth Clinic has the same link to resource and cost estimates as the general outpatient services.
Oh my God,
I made it
Daniel
hard, yeah.
and Sonia had a race to the finish line.
All right.
I'm not sure about
Guys,
the last part of it, about the financing. I don't know if we've discussed that yet.
We didn't.
All right, we'll show you. That was like super bonus. We're making it harder and harder. Daniel, can you guide us through how you did it?
Yes, sure. Can I share my screen?
Sure. Awesome.
Let me.
I'll stop sharing.
Oh, yeah. So, can you see my screen?
Yeah. Okay. Good.
So I added a platform like this. I'm gonna write anything here. And then in order to make it the first one, I moved it with clicking these 6 points and then scrolling it up to the first place. And then to link it to the resource and cost estimates like general outpatient, I just choose this option here. I don't know if that was the thing to do.
Very well done, Daniel.
We are recruiting you to join Team Speedy.
So Sonia and I.
Yeah. And then one added bonus question or bonus, you can add a code. I'll share my screen again and show you just a couple other things. So if I go back to configuration and the delivery platforms here, so I want to add a delivery platform. I'm going to call it Birth Clinic and a code. One thing you don't want to say, this is what appears when you're looking at the online platform. So typically you want to keep that 2, 3, 4 digits. So I'm just going to say birth or something like that, or I can say Birth Clinic. And then links to resources. You're exactly right, Daniel. This links to the general outpatient services. The reason why this is important, in the back end, if a country is interested in doing kind of resource allocation, they're interested in doing costing, that makes sure that the services that are being mapped at that level are linked to the relevant resources. And it's also really helpful for linking to other reference packages. So in the compendium database, there's 5 default platforms. Once the health cluster completes the work around the mobile health team, there'll be a 6th one, which is awesome.
John,
So
shouldn't, in this case, shouldn't it link then with first level referral hospital? Because you would not expect deliveries and managing simple
right, Andre,
patients.
you get a box of chocolate too, because you're actually correct. There you go. Bonus. You know, Teresa gave you instructions, but you actually overrode it because you were right. Because really the resources that are at a first referral level, not at a, man, you guys are good.
And because this group is so good, I have question number 3, which we didn't discuss, but it is something that you will.
Let's see if anybody has questions right now.
Yeah.
And then we'll come to next one. Do we have the list of who's getting Sonia, Sandra, Daniel, and
Great question from Kayona. She said, how can I add a new disease? Can you?
Oof.
That's a good question.
Add it. Tell me what you want to add.
Okay.
Yeah.
Treatment of visceral leishmaniasis.
No, a new disease. She's
That's an easy one. That's a fun one. Leishmaniasis. So you go to package, and then we'll go to communicable diseases and NTDs, and well, there we go. Leishmaniasis. So that would be easy because it's already there. But what were you thinking, Sandra, in terms of a new disease?
It's Kyono from IOM.
Oh, Kayona.
Yes,
Yes.
because I just wonder, in the future there is a new diseases, and then we might need to other option in the communicable disease.
She's clever.
Well, our team is always trying to stay up to date and keeping it updated. If you provide us the information, the SPDI platform actually can be updated fairly quickly, actually quite quickly. So, for example, if I go to communicable diseases, let's see what's here. If I'm going to go to other viral diseases, you will see Mpox. So Mpox was added.
Where's COVID?
Well, Andre, COVID is a lower respiratory infection, like
it's
many
endemic.
Other viral illnesses. There's not a special disease category for COVID, because the management of COVID would be very similar to management of other lower respiratory infections, whether you have influenza or pneumococcal pneumonia. So, a good question, Andre. So there are COVID treatments here, but it doesn't necessarily call out specific diseases. Again, the purpose of this is it's not a clinical guidance document. The purpose of it is to provide a structure to consider all services that might be included in a package. So again, it's an architecture to help support service delivery. It's not a guidance document, so to speak. All right, any other questions? Hey, when we were talking about medicines, I just want to show you that there is a medicines module, and I want to show you some of the exports that are possible. So after you have created a package, you can do an export. And I'm just going to, for illustrative purposes, I'm just going to pop up here because I haven't selected many services. So I'm just going to go back to my projects, and I'm going to open the Cox's Bazaar package just so you can get some ideas. about what an export would look like. So in the upper kind of mid right-hand corner, you'll see a box for export. And you can select the export, and there's several different types of exports that you can do. One is package details, and that lists all the services that you've selected mapped to a delivery platform, and then also linked to the various medicines and products and devices and WHO guidance and things like that. So that's one option. You also can you can also do an export for resources. So I'm going to export resources here and say next. And there's a number of things that you can do. Currently, the one that's functional is to be able to do an export for medicines, products, kits, sets, lab tests, by delivery platform. We will soon have an export to help you understand the workforce requirements and other resources that can be used for costing. That's not active. You won't be able to do that. You also can handily, for all of you working on humanitarian response, you can include a reference for IVDs, medicines that are included in emergency health kits. So I'm going to select that one here, and then I can select download. And what I will get is something, actually, I already downloaded, because I mentioned it earlier. I'm going to show you actually what happened this last week with Gaza. So Andrea's here and from the health cluster, and we were working with colleagues in, say hi, and then people know you.
Hello.
You have to say hi. I'll call you. It doesn't know you wave though.
Hello. I'll try again.
You need to talk. Anyway, Andrea's over here. So this is an export for the medicines and products and kits for Gaza. And what they were particularly interested in is looking at all the medicines that were in their 2022 OPT formulary, which you see here. The medicines that were output are listed by WHO's essential medicine list categories. So, for example, anesthetics, medicines for pain and palliative care. And then the list of the medicine here in the column F, you can see that these medicines were included in the 2022 Palestine formulary. And then on the right, you can see the last time Gaza, they had done their mapping of services, they had mapped services to their context-specific delivery platforms, which at the time when they had done it, mobile health team, I think it was mobile point, health center, medical point, I'm sorry, a health center, a PHC, and then a hospital. And then on column L, you can see the emergency health kit. So what medicines are currently available in various emergency health kits. And then over on the right, you can also see the specific concentrations, quantities that are available in the different emergency health kits. So this allows you to link, if you have created a package and you've defined the medicines linked to services, which happens automatically, then you can also make a link to emergency health kits. So this can be helpful in terms of defining specifically what resources are needed at what level, and then are they available in the emergency health kits. There's also a tab for products. So this has a lot more details that will be coming in. So you can see the specific products, kits, sets, modules that might be needed. And again, they're mapped to context-specific delivery platforms. In the back end, there's details about what are the specific instruments, sets, kits that are part of what are called packs. Again, if you're building a health system, you're having to define very specifically what are the material resources that are needed. This can be useful. Again, you don't have to use it, but it's additional information. It also can be very useful for costing. So you know what are the specific products that are needed to be able to deliver those services if you don't have them. And then lastly, lab tests. So what are the different labs that are needed? Where are those labs needed? And this can be obviously contextualized, but defining the specific products that are IVDs in vitro diagnostics. So this is an example of some of the exports. Let me stop there and see if people have questions.
Melanie wrote in the chat which clusters, and I realize now that we probably should have put it a slide somewhere, have been using the H3 or developed it. It's been developed in, and I've popped it in, Ethiopia, Myanmar, Cox's Bazar. But the tool and the H3 has been used to define packages in OPT, like Andrea has said, and plus all the medicines around it, but also with Sudan to an extent. There have been discussions in other places as well.
We did extensive work. It wasn't a humanitarian setting, but we did extensive work with Moldova, the ministries there, to define a package of services for Ukraine refugees. So they looked at some of their national package, and then they looked at the H3 package to make sure that they were meeting the services that were defined in the H3 package, which was a very useful exercise.
So I think Sandra may be aware of that for Moldova and the refugee response there, but said also because it wasn't a cluster, I didn't put that in the list because I forget. Sorry, Sandra, but very important as well. And then I can't. Whose hand up was first? Was it Colleen or Vina? Vina is first apparently, and then Colleen.
Oh, I was saying it doesn't matter, but that's fine. 2 questions. The first is this platform purpose for a country level kind of response, or is it for also partners to create responses? I see that it says Cox's Bazar, which is not the whole country, of course. So I guess maybe I have missed a really core purpose of the platform. Like I thought all partners can use it, but is it for a like MOH level working with partners? Does my question make sense?
Yeah, makes sense.
Eva, do you want to take that one just in terms of defining, or I can?
I think she's asking about this platform itself, the tool itself.
Oh, so yeah, the platform is available for it's open, especially for partners. So one thing in terms of package, there is a call to be able to define a minimum package that would be associated for each humanitarian setting, and the goal would be that partners would be ensuring that minimum package of services is being delivered there. So it could be used by partners to as kind of an assurance that you make sure that you are delivering services that have been defined in the package. So if you are a partner working in Cox's Bazar, are you delivering those services? So you could use this as almost a mapping to make sure that you're delivering those services that were defined in that specific package.
So that was what I originally understood. So thank you for clarifying that. And so the questions in the chat about developing H3, that's a different thing. This is not to do with the SPDI tool. This is talking about the H3 package. Is that right?
Well, the H3 package is a reference package, the National High Priority Health Services for Humanitarian Response. And that was, as Andre said in the introduction, it was a large process that went through with more than 80 experts across, as well as WHO experts, to define a reference package. And then each humanitarian setting, the partners there can work to define a context-specific package that would be appropriate for that humanitarian response, because each setting will have different delivery platforms. Those delivery platforms may change over time, and the capacities in the different settings will be inevitably different. So the H3 package, again, is used as a reference, but it needs to be contextualized for each setting, if that makes sense.
Also answering Melanie's question on that. We can explain a bit more. Nurian can come back and explain what happened in Ethiopia, for example. The tool is meant to be for everyone. The cluster is meant to do that with everyone. I've put a guide into the chat on how we would expect a workshop to happen. It is about everyone being accountable to this. It's about accountability. So WHO, the health cluster coordinator, Ministry of Health, whoever can't be the ones dictating it. It has to be a very honest, tough conversation on what you can do or not. I'm just going to quickly ask Colleen what her question is, and then Nurian, maybe you can explain just very briefly around Ethiopia. Colleen, over to you.
Thanks so much. When I was looking at the medicine, it says you can add a custom medicine. So my question is, do we only have the ability to work within the WHO essential medicines lists, number one, and then number two, if it isn't something on the list and say I add a medicine, it only, as of now, lets me add the name. Am I required to ask all the details, or is it only the medicine name and it somewhere else that all the details would have to go? Thanks.
So, Colleen, good question. I think if you're going to be working with the medicines module, we would suggest that we do a more detailed exercise with you. The purpose of this exercise was really an introduction to the platform. If you and partners are going to be working with the SPDI platform and developing a package, we would suggest that we have a more detailed kind of instruction to find out what the specific use case is. And if it is regarding medicines, we can describe how that is done, because it would require an entire session by itself, because you need to, if you have a formulary that you're bringing in, you need to kind of enter that formulary. You need to link it to services. But the short answer to your question is yes, you can add custom medicines. So it's not necessarily linked just to the EML. So if, like we did, actually, if I go back to the Gaza one, I think they actually added in medicines that weren't in the EML, if I recall. Yeah. Yeah, I think they had added in custom medicines that were not in the essential medicines list. So it really would be good if you are going to use the medicines module that we work with you to do that.
Okay, thank you. We try to stay within the WHO formulary as much as we can guide our teams, but I just wanted to make sure. So if we ever had to get into that aspect when we would build a package, we should really specifically follow up with you if there are some strange medicine that wasn't in any formulary that needs to be used by country X or something like that.
Right. Okay. That's a good. I mean, it's a great question, and again, because it's WHO, most of the medicines that are in there in the platform come from the essential medicines list.
Okay,
not all. There's some additional ones that. Okay, good. Other questions?
Just for the medicines, I remember we also looked at child health kit and also the non-communicable disease kit, right? John, I remember was Dr. Salim when we were going through the expert validation process, look at the non-communicable diseases and if the treatment options are available within the different kits available through WHO. So that's what we have done as well. Just quickly on the Ethiopia contextualization. Of course, the work was co-led by the health cluster and the Ministry of Health. And they have started like with the briefing the partners, and then we organized the three and a half day contextualization workshop with the 60 participants coming from Ministry of Health, Regional Health Bureau, and the different NGOs, local, international, and some like professional associations, like midwifery associations, pediatrics associations, things like that. So people come together and we looked at the H3 package, but we also added the Ethiopia Essential Health Services package, Ethiopia mobile health and nutrition teams package as a sort of like a reference package. So that during the workshop, people looked at like all the services line by line, and they discuss and they agreed, yes, it is the core at the community level or primary healthcare level, or mobile clinic can do it. So that was a sort of like workshop we conducted as a next step. So the list was submitted to Ministry of Health for final review and approval. Once that is complete, then it can be available through the SPDI platform. Over, I don't know, Andre or John, if you have anything to add on the Ethiopia contextualization workshop. And I see Sandra raise her hand.
Yeah, just to kind of outline just to expand on the process, the cluster brought together and the WHO brought together, I think, as you say, Nurian, 60, 70 experts from across the country. So they're really kind of a diverse group that had contributed to it. They used these reference packages, as you see, and then they also contextualized the delivery platforms for Ethiopia, adding the mobile health team. And I think the services that were defined for the mobile health team will be very helpful, not only in Ethiopia, but also can help inform some of the work taking place in other countries. So the process took, the experts came together for 2 days. They had done some work beforehand. So we had 3 virtual sessions with many of the partners, so they understood how to use the SPDI platform. And then we had a 2-day in-person session. We will share with you kind of a short guidance document, a quick guide about how you could organize workshops to be able to define a humanitarian response package. And again, we can do sessions virtually and then be able to support in person as well. But typically, if you bring together experts to define current service delivery, it typically takes 2 to 3 days to map the whole package. Some countries have done it entirely remotely, virtually over time, but depends on what capacity you have. So I'll stop there. Andre, you had something to bring in?
Sandra's got her hand up. Just to say, the guidance has been popped in the chat already. Unless Andre did have something, but no, he's looking at me.
No, good for you.
Sandra.
No, happy to go for Andre first. Maybe that answers my question already.
He doesn't have. He's
okay. No, I was wondering. Part of it you already just answered. The other part, I was wondering, like when you did the comparison between the Ethiopia package that you used, also, how different is it in the end? Was it like, I know it's hard to quantify, but is it like, is it like 50% the same like the Ethiopia package, or is it just then minor tweaks? And how was it to engage with the government? Because they're set standards. So I'm really interested to learn from this experience, how a Ministry of Health is then, ready to or willing or ready to accept changes in humanitarian situations. Thanks.
Yeah, I'll let Nurian and Andre explain that. But just to say, we will be doing a review process and using the learnings from the different countries where we're rolling out. But anyway, I'm going to hand over to Nurian and Andre, sorry.
I mean, in terms of like, I would say the list of actions or services we have in the H3 reference package and Ethiopia reference packages there are some difference, but I would say more or less same. But the service delivery platform is where the difference are for most of the things. And I mean, in Ethiopia, Federal Ministry of Health mobile health and nutrition team package. They have certain, for example, they have a normal delivery as for mobile clinic as something it needs to be delivered. But we know it is not possible in a mobile clinic. So, you know, like there are certain variants, but I would say, I think it was a hardcore discussion and delicate balance between what is feasible practically in the reality and what is our wish list. I mean, when people were together, yes, they want to include everything, but I'm like, okay, yes, you can, but do you think you can do it with your current, you know, HR structure, resources you have at the level where we are working? When you ask that question and people will sit back and then they rediscuss and they, you know, they shift, certain action can be delivered at what level. I think at the moment, so it's submitted to the Federal Ministry of Health Essential Health Services Department for final review and approval. I know it has been taking long. I guess.
Just to add,
Yes.
Ryan, I think that the biggest challenge is when we established working groups. I think it took 2 days, and in a similar mode as what we did for H3, we created 5 or 6 working groups where we had different partners with expertise on those diseases work on going through that exercise as John showed. Is this feasible for us, and at what level, etc. And I think the instruction was also to classify them as in what is currently feasible to deliver, or what are we currently doing. But I think there was one group that I think got lost a bit in ambitions, realizing that that we were not doing enough. And I think they added some services, particularly for NCDs at hospital level, that we thought were just not realistic or not appropriate for the humanitarian response to include. And that's why I think we advised when the first draft was done that we would discuss with the ministry that 2 or 3 very operational partners would go through the first draft with a red pen and be really dramatically strict on, is this really feasible, yes or no? The other thing, and I think John can tell many stories on this, for the Ministry of Health was very interesting. There's always a bit of hesitation in the beginning. We say, we already have a package, and why not simply do that? So it requires some discussion between the cluster SAG and Ministry of Health to explain what this adds and what the difference is. Whereas you always also highlight that by defining better what the humanitarian response can commit to do, that you show them that we want to support the national package, but there's simply some things in the national package that are outside the humanitarian mandate. But wherever we can, we will align and feed into the national package. There's 2 other arguments, and I don't know if they were applicable to Ethiopia, but sometimes in a humanitarian response, we do things that are not yet in the national package, like mental health counseling at lower levels of care. And then we can explain that by introducing this, maybe not in a national package, but that helps build national capacity. And once the dust is settled, we can work with the Ministry of Health to make that part of the package. And last is that you often find that national packages are not so well defined as the UHC compendium. So national packages often stop at a higher level of service description without going into the details of what you should then actually do for that particular service. So by showing them not only H3, but how the compendium works, they see the added value of adding those levels of disaggregation and details that you have through H3, but also in particular through the UHC compendium.
Okay, guys, we have 9 minutes left. Julie has a question, and then I know Andre's got a slide at the end. And John, if you want to fit something before that, after Julie, please. But Julie, go ahead.
Thanks so much. This is really great, and it's more than enough to wrap my head around at the moment. I did wonder, though, because I'm super intrigued about the workforce component, which I know we're not going through today. It's not ready to go live, but just wondering, in terms of sort of the algorithm, is the idea that we build out the package, and then from there it tells us what the workforce needs are, or how does that interface with this? Because that is such a limitation in so many of these settings in terms of availability. So I just wondered the sequencing, I guess, or how that fits in, if you can just briefly talk to that. Thank you.
Super important. Obviously, if you don't have the health workforce to be able to deliver the services, there's going to be problems. So we are actually receiving a lot of requests from countries to be able to add a module for health workforce, so that once, if a package has been defined, looking at what services have been defined for different levels of the health system, and then defining what health worker is really responsible for the delivery of that service. And then have they been trained? Is it within their regulatory scope of practice, which is an issue that we have encountered working in countries. Lao PDR, for example, did an analysis where their midwives it was only in 22% of the services that they had been assigned that they had to deliver, they had the regulatory scope of practice to do. So they had to change their regulations in order to make sure that they could deliver those services. So there's many different ways to be able to do that. We think this is really important. This module will be up and coming. If it's something that the partners want to do, we would love to get feedback about how that could be utilized in different settings.
Thank you.
Great. I was just about to talk to myself. John, is there anything else you wanted to show to the group, or can we go to wrap up?
Yeah, I think we go to wrap up. Again, very happy to do a deeper dive into other areas, or if you really are going to, if you partners in a given setting are planning to move ahead, we can organize some additional more focused work, because again, each setting is different, so the context is different, and can help to design the process to meet your needs. So back over to you, Eva, and thanks everybody for playing Speedy Bingo.
That's hilarious.
Have a list. So Sonia, Sandra, Daniel, and Andre. I like chocolate. See you.
Norian, did you have something to add?
Yeah, just one point. I mean, this or at least H3, it like itemizes the actions you need to do. So it's not the package. We don't have IMCI, we don't have ICCM. So it is like what actions need to happen for a specific condition or like issue. So I think that gives from the project managers or like people who are designing interventions, that gives them a lot of details. And you also can look at what are the specific services at the moment you can do at the primary healthcare level or referral level that, or you're supposed to do, but you cannot do because your staff are not trained, you don't have the supplies. That also gives you sort of like plan, what are the things you're supposed to do, but you're not doing, rather than saying, okay, I need to do BMOC, but under BMOC, what actions are happening at what level and what is missing. That gives you a more specific, tailored intervention to sort of like update and make sure you are delivering services based on what is recommended. Over.
I think you just did the wrap up. But that was beautiful. Let me hand over to Andre so he can say in a different way what you just said.
Yeah, so just when you thought you were done, one of the things that we like to work around packages is that they are an entry point for other things. And they are the package in a way is the backbone to the body. Yeah? When you describe it and you're more explicit about it, you have the skeleton for many other things that you need to do before, or that will support you to do many other things. Now, if you are explicit about what you can deliver, you can actually communicate very clearly to the affected population what they can expect from us. So there's this mutual accountability and sharing information with affected population of what they are entitled to. We talked a bit about the resource requirements. As John showed, you can make exports of the medicines and equipment that you need. You can have your discussions around health work competencies. Obviously, health workforce is often a limiting factor, but if you think you have a hospital, but it doesn't have a doctor, it's not functionally a hospital. And even though the hospital has a list of services that can be delivered at that level, if that doctor is not there, but there's only a nurse, functionally that hospital then is an outpatient clinic or a primary healthcare center, depending on your context. Now, the other thing is that your package design reflects also the foundation for a model of care. It's not only the services that you provide, but also how you manage them, how you manage your outpatient, what services are managed on an outpatient level versus people being hospitalized, and how do you organize your referral pathways between the different levels of care. For me, one of the key things is that you have discussions around what is the right mix of delivery platforms in different operational contexts. And we could have another hour session with Nurayan, or we have actually in other workshops. They developed a decision-making tool that helps you to define for different operational contexts, for example, highly insecure, hard to reach, limited ability to have permanent presence, more stable, more accessible, yes or no presence of development partners and programming. And that helps you to go through a very systematic process of knowing, in this particular case, we should invest in community services and mobile clinics. And in other contexts in this country, we should support static facilities as our primary interface to deliver services. And this really helps you to have a more diversified, specific operational strategy for different operational areas in your country. As John said, it can also be used for costing. They are working on an application in the compendium and thus also available for H3 to add costs to it. And if that's the case, we have a great reference also for this unit activity-based costing that OCHA is asking clusters in many countries to apply. The more specific you are about what you do, the better you're able to cost those services. In situations where the humanitarian response doesn't support secondary referral and tertiary care hospitals, you can still define which referral services you want to support. Just as an example, the repair of fistula for women that had significant complications during delivery, something that can only be done at tertiary care level. So you may not support all specialist services, but if there's a conscious decision that you want to support women to have that type of reconstructive surgery, you add it to your package, but then you see with that tertiary care hospital how you facilitate access for that particular reconstructive surgery. You reimburse the hospital, for example, for the services provided. Also, if you subcontract with national local partners, again, it's a way how you can define better that, okay, these are the services that we expect you to deliver, and this is how much money we will give you for doing so. Gives you program monitoring reporting. Another thing that we're trying to stimulate more is not only not to stop at the discussion of what we make available, the things that we supply, that we make available, but also that we then have discussions on whether or not patients are able to get to the clinics that we support. So looking at all the barriers, and there's additional guidance on how to do that, but obviously there's financial barriers, but there may also be social, cultural barriers or religious barriers for people, preventing them to actually come to your clinics, or perceived poor quality of care in the facilities supported. And entry point to the HDN. Last slide, and then we're done.
Sorry, yeah, we're already over time, so.
Okay,
Yes,
so entry point for the Nexus. Again, the harmonization of our humanitarian services with national standards, medicines and staffing standards and treatment protocols. I think if you embark on training of staffing for in-service or shorter courses, so that they can implement the services that we may classify as conditional. If you develop these curricula together with the ministry, make sure that the people who get trained are certified, that they get a formal diploma and not just a printout of an NGO that they did a certain course, and work with the ministry that additional training also gets included at some point in national curricula. You really make a contribution and you build on national capacities. Looking at facility standards, quality of care, staff and patient safety procedures, yeah, and this aligning to national packages and stuff. Okay, good, that's it.
Okay, that's it, guys. I can't believe you're here for so long. I don't know how to switch this off. Oh my God. Stop share. Look at that. Okay, we have survived 2 hours together. You guys have taught me loads as well. I kind of thought I knew the tool, but each time I learned something else. Thank you so much. Our door is always open. Please contact through Health Cluster. Even if it's for UNHCR, it's fine. And we'll link you up with John's team or whatever for whatever you need to do in refugee response. Please take it forward. Andre is obviously there and John. But yeah, any questions, please reach out. Any support. If you think you want a special session somehow, we can try and look into doing it somehow. We will be recording this. This will be available. So if you want your team to really listen to us babble on and play bingo, possible. Thanks so much. I'm going to let you go. And you have to leave, otherwise I will just carry on talking.
Thank you.
Bye.
Thanks everybody.
Andre, stay on.
Bye.